you for braving the fog or the snow in some cases and getting here. I think we have a little bit lower attendance because we heard that it snowed in Southeast Washington. So we're expecting a lot more people to be online this morning, but I just wanted to thank everyone for being here for this learning collaborative. This is kind of the culmination of a lot of hard work by all of you to get to this point where you really understand now why we are doing need-centered medical homes and the benefit it has in terms of value-based purchasing or payment. We are so excited to have Adam Falcone with us today, and Ron's going to be doing his introduction in a few minutes. But my name is Carol Moser. I'm the Executive Director of Greater Columbia GCACH, and we just wanted to thank everybody for being here this morning. Diane wanted me to do a couple of housekeeping things. The bathrooms are out to the left, go out the hall to the left. And if you haven't picked up a Greater Columbia GCACH mug, we invite you to do so. That will remind you of us when you're having that cup of coffee in the morning. But we just want to thank you again for Diane, was there anything else? What about the ticket? Anybody park in front of So Diane was saying if you're parked in front of the Red Cross, please move your car. They need access to their building. Anything else, Diane, before we introduce Adam? What about roll call, or how are you handling that for people on the phone?
There is a chat box.
Okay. So if you do have a question, we'll be monitoring the chat box. So feel free to send in your questions, and Chelsea can bring those up to Adam. Otherwise, I will invite Rhonda Huff, our president of Greater Columbia, to introduce Adam. Thanks, Brenda.
So we are really excited and happy to have Adam here. Adam Falcone is a partner at Felton, Tucker, Leichter, Fidel, and home based in Philadelphia, Pittsburgh. It's one of those two. Adam has, thank you, Chris. We're getting ready to start the morning. Adam has a specialty in managed care contracting, compliance, and value-based payments. He's a partner in the health law, nonprofit and corporate law, and federal grants. Mr. Falcone counsels clients on a wide range of health law issues with a focus on fraud and abuse, reimbursement and payments, and antitrust and competition matters, representing a diverse spectrum of primary care and behavioral health organizations, ours being one of them, so that's one reason why it's my pleasure to be here. He knows firsthand the value of clear, affordable, and legal advice. Adam and his firm lead issues of care, corporate compliance practice, offering proactive counsel to avoid and help clients avoid costly legal missteps that can jeopardize the provision of health services within their communities. Drawing us on his extensive knowledge of healthcare policy and markets, Adam regularly speaks to groups across the country on managed care contracting, value-based payment methodologies, and health reform opportunities. In particular, he brings strategic counsel to clients that are responding to changes in their local marketplace, negotiations, and participating providers. And I would say years ago when we started in managed care contracting, Adam did a lot of work helping us with our contracts. There were new managed care organizations in Washington State, and just understanding what we were agreeing to was a huge help for our organization. And we met through the National Association of Community Health Centers, and over the years, I wasn't quite sure if he thought I was a stalker or a groupie, and so I'm hoping to officially announce that I'm actually a groupie and not a stalker. So with that, I'd like to introduce Adam Falcone.
Can everybody hear me all right? Is it working?
Good. I'll turn it up a little bit.
Glad to be here back in Washington State. I feel like I've been here so much. It's like at home. It's been the whole state, basically, over the last, 3 years now, since behavioral health has been integrating into managed care here. Usually I start off the trainings by asking folks to give me an introduction of who you are and what issues are concerned. I think we have such a large group today. I don't know if that's the best way to spend our time together. So I'll do a little bit of an introduction of myself and how I got to this strange strange enough for being an expert on managed care. It's something that I thought about that I wanted to do when I was growing up. But then maybe I'll open it up for some questions and comments so that I at least can hear from you if there's particular issues of concern that drove you to attend today, other than your boss just telling you to be here, so that you can share this back with me. I've always found that these trainings to be most helpful. It's best to have some kind of dialogue that goes on, makes it more interesting for me and more engaging for everybody to do that, and more tailored to the concerns that led you to come today.
I gotta click on it.
Okay.
Now try.
So I'm part of a kind of quirky law firm. We're based there, so our single office, even though I live in Pittsburgh now. We represent historically nonprofit federal grantees. That's where our healthcare sector is out of. We have a large, for the last 40 years, we've been representing community health centers, Title 10 grantees, right grantees, really the safety net providers. I would say in the last 10 years or so, I've been sort of on the A team for expanding our services to behavioral health providers who are now facing a lot more regulatory issues through states that adopted KBHC models, states that were implementing arrangements to carve behavioral health back in, and behavioral health entities that traditionally have been underfunded by our public insurance programs and sort of left outside of some of the other resources that other providers had. So definitely an underdog from that perspective. We don't represent MCOs. There's a couple of exceptions. Some of our safety net providers started their own managed care companies, so provider network. Yeah, certainly we represent them from that perspective. But we don't represent any of the big players, Wall Street, for-profit MCOs like that. We do litigation as well. Sometimes we sue states on behalf of those providers to make sure that the state is living up to their federal requirements. I ended up in managed care completely by accident. I was a biology major in college, but I was going off to med school, and then I passed out almost when I saw blood. So probably not as I manner with your physician passes out. So I kind of had to shift gears and say, what else can I do? I like healthcare. I was a biology major, and I said I really like the advances that were starting to be possible through looking at molecular biology and biochemistry and genetics. I kind of had to shift, and then I had an epiphany during college, which was all these great medical advances, do a lot of good, and have access to healthcare coverage that allows them to benefit from those therapies and development. I kind of shifted gears into health policy. Spent a couple of years trying to figure out after college whether I wanted to do a PhD in health policy and go that direction, or get a law degree. Now there's a little bit of an echo here. Is that okay? I'm going to stand over here. To do that, and I decided to split the difference. I have a law degree and a master's in public health, which was interesting because it allowed me to do some policy work in D.C. And the association I joined after leaving the Justice Department represented nonprofit managed care companies, folks like Group Health Cooperative, Puget Sound, Kaiser Permanente, Health Partners, the more staff and group model MCOs, which definitely invested many, many resources into their provider systems. I know it's a different creature than many managed care companies. I sort of say I saw the good guys in managed care, and I know there's some not so good guys out there, but I saw what managed care companies can do when they really embrace population health management tools and really think about how they can set up providers and their patients to do well. So today's agenda sort of divides up into three parts. The first part is starting to figure out where your leverage points are and give you a game plan for dealing with managed care companies. Some of you, I presume many of you, are already engaged in contracts with MCOs, but you probably want better contracts that offer additional value-based payment incentives and that sort of thing. So I'll talk about where your leverage points can be. I'm going to talk about how you evaluate a managed care contract, because you will be hit up even if you sign a contract with amendments all the time, and you want to be looking at those and examine them and understand how to read them. So I'll just go through understanding that. And some tips for negotiating MCO contracts. I've seen all the planned provider agreements in Washington State because they've been offered to clients of ours, but I had a chance to see them. I understand what they say. I've also assisted in the back end of negotiating hundreds of contracts both here and in other parts of the country. I've seen contracting from both sides. Those clients who started their own managed care companies, I wrote many of their provider agreements. So I've seen what the contract should say from both perspectives, and I'll share that information with you in regards to negotiation strategies. Part two, we'll look at key provisions in those contracts. Some of your eyes might glaze over certain clauses in those agreements. I don't take offense about that. I didn't write those contracts, probably. But I'll explain to you what those provisions mean really in layman's terms, and which are advantageous to you, what are good provisions, and what are less advantageous provisions. What kind of provisions should you avoid to reduce your risk? And then part three, I'm going to talk a little bit about participating or forming a provider network, because some of you might come to the conclusion after hearing the first two parts that if you can bundle yourself together and be part of an integrated provider network, that you'll have the access to additional dollars, additional revenue, be able to take higher levels of risk with other partners and partners in the community, and be interested in doing that lawfully under the federal antitrust law. All right. Let me just stop there and take a moment to hear from you, if anybody is bold enough early in the morning here, to share what concerns you've had either through the process of negotiating MCOs, what you're feeling that you're not getting, why you came to the training today. Whatever you'd like to share. If you have kids, you can talk about them. I'm happy to do the same, whatever it is. So let's see if anybody takes the bait here. Yes. We're going to bring a microphone. Are we going to bring a microphone so people remote can hear you?
I'm Penny Bill, and I operate an outpatient substance use disorder facility. And I know one of the concerns amongst the providers is in trying to contract with the managed care organizations. A couple of them are just cut and dry, take it or leave it. And I'm hoping to find out we don't have to do that.
Yes, you will. You will find out. Great question. And I'll give you some arguments that you can marshal against them if you hear that this is a take it or leave it kind of contract. Other comments, concerns, questions, things people want to share. Yes. The microwave is on its way. Don't worry. Microwave is coming down.
One of the concerns that I have is in the contracting is making it to where the MCOs are more responsive when they're denying your claims and trying to then get them either paid because their errors they weren't paid versus us having to rebuild everything they denied. We've run into this with one of our big MCOs and $4,000 out because they keep making problems. And they're saying, well, you have to rebuild. Well, that's time on my end. And how do we put that into a contract that maybe it's not our issue, or we work it out a little better than kind of like Kenny said, you either fix it or you don't get paid.
Yeah. And many MCOs, unfortunately, will make the same error multiple times over and over again, and result in many denials without actually fixing the core underlying issue.
Yeah.
Great, thank you. See, I've been up for more hours than you probably, since I'm still on Eastern time. I'm geared up and ready to go.
Morning. Just a couple of things. One, I'm glad to see you're going to talk about terms and language and whatnot.
And it is sometimes like the management companies have their own entire language.
Upside-gation, downside risk, upstream, downstream, there's different words for things. Just to make sure when we're talking to them, that we know what they're saying.
Yeah.
I'm also on the U.S. side of things for comprehensive health care, and so I've been trying to get information out from one hard agency I was looking for around UM and contracts, and oftentimes it's very vague around that.
Pretty silent usually. That's right.
That would be.
So Adam, I wanted to bring out, a presentation that the healthcare authority gave to all the, accountable communities of health on Monday, and this is showing the MCO BBT adoption by accountable community health, and you can see in the lower right-hand corner, that big blue Greater Columbia ACH with the lowest percentage into BBT contracts. I happened to be with some of the MCOs yesterday and asked the question, what would be the reason that you have this low adoption to be going inside? And one of the responses was, well, if you have a small Medicaid beneficiary population, we're less likely to take risk. So I'm hoping that you can give us some ideas if you're provided with a fairly small Medicaid population, what kind of contracts can you get into, and that would be probably more performance-based, and how do you negotiate that? So not only can we elevate that number, but this is how we get paid. Is the state of Washington is with this program, 90% of all contracts, Medicaid contracts, are based or risk-based arrangement by 2020.
I prefer to say value-based payment model, because that's what the metric is. From my health background, how many in the room are employed by organizations that provide either just solely mental health or addiction services, behavioral health providers? Okay. How many work for primary care providers, FQHCs? How many work for hospitals? How many work for any managed care companies? I have to ask sometimes. I don't ask. Really somebody from the room, and then they take offense at everything I'm going to say. How many work for a BHO? Anybody BHOs? Okay. Did I miss any types of provider groups? Okay. And just give me a sense for payment methodologies. I'm not asking for how much you get paid. How many get paid by the Medicaid MCOs under a fee-for-service model? How many get paid under some kind of fixed payment per month capitation or fixed fee? Okay. All right, that's good to know. That will be very helpful. What's it? Back to me. Yeah, there's no reason why it should be so low on the 54 in this region. And I'll give you some of the reasons why it shouldn't be and what the MCO should be contracting with you in a way that allows them to achieve that metric. I don't see why rural providers should be any different than in other regions. All right. So we'll dive in now. And here's the proviso. Please feel free and comfortable to raise your hand and stop me if I speak too fast like an East Coaster, even though I grew up in California. It's very interesting. If I use a term that you're not familiar with, you'll probably share that unfamiliarity with other people in the training, so don't hesitate to ask me. If questions come through online for the people hearing me remotely, feel free to pause. If a question occurs to you or a comment, just don't hesitate to stop, because the more engagement, the better. It also gives me a moment to catch my breath, and it ensures that my voice will last the whole day during today's training. So I always welcome questions along the way. Sometimes you have to raise your hand and wave it vigorously, because I'll just miss it. Just don't hesitate to do that. My law firm always makes me include this slide. This is just to tell you that I'm providing this for educational purposes only, and no attorney-client privilege is being created. If you want an attorney-client privilege, then hire an attorney for that and to receive that kind of counsel. All right. So I always start my trainings with this slide, with a big sumo wrestler area up against the little guy. Because intuitively, we would say that the big sumo wrestler has an advantage in that contest. And my view is that both have certain advantages. And you might, follow a guy, he probably can run circles around the big sumo wrestler. The big sumo wrestler might have a huge disadvantage. He might be toppled off of balance more easily because of his weight. And so just because somebody is larger than another doesn't mean they have all the advantages. And many of you might feel like you are very small compared to managed care companies. And you may be based on revenue and size. But the secret for any kind of negotiations where you have a contract negotiation with another party that's larger is to recognize what advantages you have. Because you will still usually have advantages, even if you're smaller than the adversary. And so to really take most advantage of that, you really kind of have to have a contracting strategy, in my view. Most people like to have, strategy is a fancy word for a plan. Most people like to have a plan when they go into battle with with a larger adversary like an MCO. Since I went to a law school that cost a lot of money, they taught us how to make acronyms. So the acronym that I've created for managed care contracting purposes is that before you sign the contract, that you prepare, evaluate, and then negotiate. Those are the three pieces, those three pillars, I think, to achieving a successful outcome with an MCO. Doesn't mean you have to do all three elements every time you get a managed care contract, but the fact that you've gone through the process, at least the preparation process first, to figure out where your leverage points are, will give you sort of the ammunitions you need to do well against subsequent plans thereafter. So the most important phase in this process is the preparation phase. And this slide shows a picture of David and Goliath, a biblical story. And I start out with this because Malcolm Gladwell wrote a book called David and Goliath, which sort of questioned in common culture some of our, perceptions of certain beliefs that, people who have certain disadvantages and what it's like for them, and that they may actually have some advantages in life. And he gave us a number of examples where people had certain limitations, were able to turn that around and actually accomplish great things. And the story about David and Goliath he gives in the book is that in common culture, it's a miracle that David was able to overcome his adversary Goliath and defeat him. And Malcolm Gladwell says that's hooey. Like, look at the advantages that David had when he went into battle. First of all, he had a very powerful weapon. That slingshot, which he, swung around, had the same force of a gunshot today. Moreover, he could safely stand far, far away from his adversary, safely on a hill, unlike the picture on the slide, but safely from his adversary, meaning he could use his weapon against his adversary without inflicting any harm or risking harm to himself. That's a very powerful advantage compared to Goliath, who was expecting hand-to-hand combat. In addition, Goliath was probably expecting someone that looked kind of like him, that had similar armament, that was going to engage in close hand-to-hand battle, and was not expecting this little scrawny kid here as his adversary. There's also some, there's can be historical biblical thought that perhaps Goliath had a few disadvantages of his own. Perhaps he had some disabilities. Maybe he couldn't see quite right. Maybe he couldn't run very fast. So maybe Goliath, even though he was bigger, had disadvantages going into battle. So Malcolm Gladwell says it's not surprising that David was able to defeat his adversary Goliath because he had certain advantages himself. So my view is you have to recognize where your advantages are before you go into contracting with the MCO. Because as you know from experience, I'm sure the MCOs are not going to point out to you where your leverage points are, what your advantages are, what you can really ask from them. They won't tell you that. You have to do your homework first so that you can use those advantages to your benefit. So when you're identifying strengths, I'd suggest you focus on sort of three different aspects of it. First, looking at where your leverage is today and trying to assess where your biggest leverage points against the MCOs are in order to obtain a favorable contract. Second, compete on value. Washington State is definitely a leader among states in pushing the whole healthcare system, transforming it away from volume towards value. So you want to set yourself up well to compete based on value. And the activities, for example, by the accountable communities of health is really in part for delivery system transformation, to try to prepare the delivery system to do well from a value perspective. And then because the MCOs provide the largest share of revenue for many of you, you want to set yourselves up well to be rewarded for that value providing to the MCOs and share some of those dividends. And then lastly, if you come away from today's training feeling that you don't have the leverage that you want or aren't quite ready to compete on value, I'll give you some ideas for where I think you might want to focus your time and attention to increase your leverage in the future. So let's start first with the legal leverage points. This is where there's some legal obligation, usually incumbent on the MCO, that gives you some advantage in the contracting negotiation process. So the three questions you would want to ask yourself at the outset is the MCO required to include me in their network? Because if the answer is yes, of course, then really they can't walk away from you. In a situation like that, where the MCOs are obligated to contract with you, they must contract with you. They can't play this game where I've seen in other states or in some states where the MCOs say, to heck with you, we have enough people in our provider network, we don't need you anymore. So these are the types of issues that basically take certain issues off the negotiation table. The next is coverage. do they have to cover all the services I've rendered? I have some MCOs that like to cherry pick. They pick and choose the services that they're going to contract with providers on, saying, oh, we have enough, these types of providers. We just want this type of service from them. So do they have to cover all your services? And then 3, do they have to pay you a specific rate for those services? Is it mandated by law? So, for example, in the DC Medicaid program, District of Columbia Medicaid program, it dictates to the MCOs that they have to pay certain designated safety net providers a particular rate. What does that do? That means the providers don't have to negotiate on that rate because the state has already told them this is what the rate is that you get. In New York State, which basically started their GCACH program probably 5 or so years before Washington State moved into GCACH, all the behavioral health providers, they are guaranteed a state rate. It's the Medicaid rate, but New York State is upside down in a way. The Medicaid rate is the best rate in the state. So those providers want that rate. So rather than being an unfortunate ceiling, it's actually a great payment floor for them because it is actually a fantastic rate that no commercial payer pays near that rate. It's about twice as much as any commercial rate, if not more. So now in New York State, behavioral health providers are happy to contract with Medicaid MCOs. They get, if they can be in the network, because they get a guaranteed rate, which makes them very happy. So where do you look for these sources of leverage? Well, one place I start out, because I'm a lawyer, is the federal Medicaid managed care regulations, because they do impose requirements on states for how they set up their Medicaid managed care programs and deal with issues like actuarial soundness and network adequacy, how many providers have to be within an MCO's network. The second source of information I look at is the state insurance laws or regulations, because there could be specific protections for providers around network adequacy issues built into state insurance law. But my favorite source of leverage, and the one that is really best here for you, is the MCO's contract with each, the HCA's contract with each MCO. That's called the model contract. And Washington State is a great state because they're very transparent. You can go online and actually download the entire model contract between the HCA and each Medicaid MCO. This is the source of all your legal leverage. I'll have some slides today that I'll show you. Those slides are largely taken from the model contract. Why is it called the model contract, by the way? Because the state's not actually sharing with you the actual documents that the MCO signed. It's the model, it's the template that they use to contract with each of the managed care companies. So presumably, the document that was actually signed reflects exactly what's here, what's exactly in the model contract. So I'll be referring a lot today to the model contract because that's where your protections live. And Washington State actually is really good to providers. You have some very favorable language both in your state law that applies to any kind of provider, and you have very favorable language in your model contract, particularly in regard to behavioral health providers. I'll talk about what some of those protections are. Some states have insurance regulations or insurance exchange regulations for insurance products that are offered by MCOs on their state-based marketplace, and sometimes that's worthwhile for looking at as well. You can save yourself looking through the entire, this is like double-sided and multiple page printed, because these documents in the contract, they run 300 to 400 pages. I would suggest downloading the PDF and doing searches for certain key terms like provider network, network adequacy, payment, network contractor requirements. So you can zero in on just the aspects of the contract that are probably most relevant to you. Let me give you an example. This is language taken from your model contract, and it defines what are called essential community, essential behavioral providers. This is the most advantageous or protective language I have seen in the country, because it's not telling the MCOs that they just have to offer their standard contract to behavioral health providers that render these services. It actually imposes an affirmative contractual obligation to contract with such essential behavioral health providers that render these types of mental health and addiction services. They cannot walk away from you. If they walk away from you, essentially they're violating their contract, because the language I bolded here, shall establish and maintain, is an affirmative contractual obligation on their part. And that's why it's such a strong protection for behavioral health providers. It means that if the MCOs, for whatever reasons, don't include these types of providers in their network, they're not in compliance with their contract. And let me tell you, they want to be in compliance with their contract. Millions of dollars are funneled to them from HCA. They are worth a lot of money. And they know that if they do not comply with the terms of their contract, not only can they have repercussions under their current contract, meaning they could lose lives, the state could decide to close enrollment for their plan, they could have financial penalties imposed upon them. It also means that when the state rebids managed care contracts, they will have a track record if the state finds that there has been non-compliance in their performance under the prior contract. So plans don't like, they don't like providers complaining, number one, but they don't like findings by the state that shows that they've been not compliant with the terms of their contract. Yeah.
So, okay, clarification on what. So, my question is the managed care company then required to contract with all of the behavioral health providers that offer these services, or even though it's duplicative?
I interpret this language to mean all.
Okay.
And one of the reasons I do so, and I would encourage you to do so, is because this is in a provision called essential behavioral health providers. It means you're essential. And it means how many of you are there doesn't matter, but you're essential to making access to behavioral health possible in your community. And particularly if you're in a rural area where you're the only game in town, absolutely you're essential. But maybe even if there's two, because you know you have capacity limits. So the services might overlap, but it doesn't mean that each can replace each other in regard to capacity. So yes, I believe it means all essential, all providers that furnish these particular services.
But in reading the model contract, also it states that because maintaining a contract established and maintained doesn't say anything about the rates. So you get a certain rate in this area, you get non-par rates anywhere you go if you open shop. They have the National Health Care Authority rates. Is there anything about that where they have to match? I thought I understood the contract to state that you have to do what they're doing to your neighbor down the street.
They don't have to treat everybody the same, if that's what you're suggesting, that they don't have to pay you the same as they pay everybody else. This has nothing to do with payment. We'll get to payment,
Right.
but this is nothing about payment.
Is there anything about that we can do, though? If I choose to go to a location I'm not contracted for money, and I'm providing now non-par services, where I can negotiate rates there, because I'm getting all the no's, we're not contracting for any more money for anywhere else. Okay. Is that something we can do?
Yes, there's a slide I'll share with you in a moment that talks about your right as a non-par provider. But notice that this clause has nothing to do with sort of your region or outside different sites. This applies to you across the board. So it doesn't matter, it shouldn't matter where you open up shop, you're guaranteed a contract, even if it's in somebody else's region and you're providing services within that region. Talk about enforcement too, for what happens if the MCO doesn't comply with some of these contractual requirements. So in behavioral health, there's no payment floor. There really is no payment floor, unlike some other providers that are guaranteed particular kinds of payment methodologies. So if you were an FQHC, for example, the model contract goes to some length to explain how much the MCO has to pay. So they have to pay a certain amount equal to PPS, which is that payment system set up for FQHCs, and they give a couple of different ways they can do that. Plans can pay going rate, fee for service, and then pay a bump after that later on, or they can just pay a monthly capitation rate that includes that PPS standard, but they have to pay at a specific level. So sometimes I hear from the states that, oh, we can't dictate to plans how much they pay providers. Not true. Many states dictate to plans how much they have to pay certain providers because they want to ensure payment for it. So here, this is related to FQHCs, and as I mentioned, in New York, for example, they guaranteed a specific rate to behavioral health. So there's nothing in federal law that bars the state from setting up a minimum payment floor for any type of provider in the Medicaid managed care network. It's up to the state to decide, and that's where advocacy efforts by different associations are very helpful to try to encourage states to provide very progressive language to ensure rate adequacy. So you talked about non-par providers. There's a very curious provision in the model contract that actually addresses payment. And it suggests to me that you can't be left out in the cold if you're a non-par provider and you furnish services to an enrollee in the plan. So there's some language about emergency services, but when you put that aside, it says the contractor shall coordinate with and pay a non-par provider that provides a service to enrollees on this contract no more than what they would pay basically for similar providers in the state. So the way I interpret that language is, first, they have to pay that non-par provider. Second, they have to make sure they don't pay them more than what that MCO would pay one of their network providers in the network. So they can't pay more than they pay a network provider, but they have to pay them at least that as that's a ceiling. That's what they have to at least pay them. So you are entitled, in my view, to payment as a non-par provider. It's a very curious term. It's not that I don't think it's a model of drafting in the model contract, but it's an unusual term that I don't see in a lot of contracts. In other states, you usually see if you're a non-par provider, you have no rights, MCO has no obligations to pay you. But it looks like this HCA here was trying to protect non-par providers who didn't have a contract for whatever reason and ensure that they at least got paid something. Now, to be fair to the MCOs, not have the MCOs have to pay more than what they would pay a network provider, but to ensure some payment for the services by a non-par provider. So I would argue, if you're a non-par provider with an MCO, that I would use this provision as your leverage point to say, you have to pay me, and you have to pay me what you basically pay a network provider. That's how I would argue it. There's also some very, I think, forward-thinking language in the model contract about behavioral health providers and the role that they could play, maybe as a patient-centered medical home. I don't see this a lot. This isn't a provision that talks about enrollees having their choice of PCP, but it includes behavioral health professional as a possible individual or practitioner that might be the right one to coordinate their care. And I think that's interesting because it basically illustrates to me that maybe HCA realizes, or maybe the policy people realize, that for certain patients who are going through addiction issues or other mental health issues, that maybe that's the type of provider they're having the most interface with in their time, and that maybe they are thinking that that type of provider hopefully has some kind of integrated care model and maybe would take responsibility for also coordinating patients' primary care needs because they're not engaged maybe with their primary care provider that's maybe been assigned by the MCO or whatnot. So it at least opens the door, I think, for behavioral health to have a much more critical role in managing a patient's care. It's important to emphasize that in New York State, for example, the behavioral health providers have been largely left out of a lot of value-based payment models that are in the state. Left out because can't be attributed lives to coordinate. They can't be viewed as almost like a mini PCP. But I think this is encouraging because it suggests to me, at least maybe in Washington State, if you're just a behavioral health provider, maybe you won't be totally left out in the cold, that you can be attributed patients. And I know from my work in Washington State that some of you are paid, a capitated rate and are attributed lives and membership lives from the MCOs. That's very encouraging. It doesn't happen everywhere in the country like that. New York State, it's not happening at all. But at least in Washington State, behavioral health providers are being attributed patient lives and populations. Yeah.
So, when we spoke with several months ago, Living Collaborative, one of the questions that we had was, the MCOs were not attributing patients to the behavioral health providers yet, because it was, I don't know what. Are you saying that the behavioral health professional in the BHO can be identified as a primary, and therefore they could be, the patients could be attributed that way?
So let me answer that in two ways. First, there are MCOs in Washington State that are attributing patients to a behavioral health provider. I've seen it in the payment methodologies. You may not be one of them, but there are behavioral health providers that get attributed. Basically, they get a capitated rate for behavioral health services, just like they used to receive from their BHO for the scope that they do. Every month by the 5th or the 7th, they get those dollars, and the MCOs attribute every enrollee basically to, in their county or by zip code, if there's multiple behavioral health providers in the county, they get all the capitation for those services
for their zip code, for their enrolling. So there's an attribution process already going on in Washington State, which is way ahead of other states, where behavioral health providers are being attributed lives under a capitated payment methodology. So yes, that's entirely possible. And if the MCO wants to, there's no reason why they couldn't attribute lives for primary care services if they wanted to, and you wanted to, be responsible for that scope of services. It's all negotiable. Many MCOs push back on doing that because put yourself in the MCO bus. If you're steering that bus. MCOs are, in many cases, traditional insurance companies. Their traditional model is fee for service, and their attribution methodology traditionally is primary care. So they are being pushed away from their comfort zone. So you may well hear from many MCOs, we don't do that, or we don't want to do that, and some intransigence. And you have to work hard to overcome that, either by pointing out to them that they already do it, in some cases in other regions in the state, or number two, it's in their interest to move away from that model to what you're proposing. Was there another question on this part before I move on? So that's the legal leverage stuff, and we'll come back to some of those points more when I go through the key terms and legal protections, part 2, because I'm going to bring it up where it's relevant, where there's particular protections in the model contract that will, that basically should supersede any existing terms in the contract that the MCO is offering. So what's the next set of leverage? The next leverage point is really market power. And market power has to do with whether there are other providers in the area that you furnish services that you're competing with. Because if you're in a rural area where you're the only provider in town, then you have significant market power. And I know there's always, an interesting pushback between urban areas and rural areas, and many folks in the rural areas are sometimes envious of what's going on in urban areas and vice versa. Don't forget, in rural areas, you may have significant leverage that you wouldn't have in an urban area. In an urban area, there's usually lots of providers, which means there's lots of competition, and you may have an MCO that can do things to shift populations from one provider to another. Not so in a rural area. If you're like a sole community hospital, you're the only game in town. One of the reasons why healthcare is viewed as more expensive in rural areas is because sole community hospitals can basically dictate rates to managed care companies. It makes it very hard for them to form provider networks. But it's not limited to hospital services. It could apply to primary care or behavioral health just as well. If you're the only entity or one of a few entities that furnish those services, you have a lot of leverage, and the MCO need you. Let me give you an example of how that plays out. In New York State, I had a behavioral health provider, and they got a call one day from MCO. The MCO wanted to amend their contract to add a service in that they had excluded initially. Why had they excluded a service? Because they had another provider at the time of contracting that rendered that service. This is one of the situations where they kind of slice and dice, and that provider who furnished a service could not get that service included within their scope of their contract. But one day they got a call. The MCO said, we want to now include that service. So they had me call the MCO contract rep, and the first thing I asked them was, why are you adding this now? Why didn't you add this service, back when we formed this contract, a couple of years ago? And the MCO contract rep said, well, our only provider of that service just terminated our contract with them. So we need to fill that gap. And I said, thank you very much. You now tell me everything I need to know. We have significant leverage now on the rate piece of that service because we were the only game in town. We were the only other provider in that particular area that could render that service. And we knew it, and we played it well. In fact, we actually played it to give us some advantage on the Medicare contracting side as well, because on the Medicare side, they were refusing to pay more than, I think, 85% of the Medicare fee-for-service rate, and we told them we won't contract for less than 100%. From our perspective, why should we accept anything less than 100% if we know the plans are compensated at rates that approximate 100% of Medicare rates? And the contract rep said, no, we don't ever pay more than 85%. And I said, okay, we won't just include it in our contract. We will just carve out Medicare. We'll do Medicaid, but we won't do Medicare. And then a couple of weeks later, we got a call and said, well, we'll reconsider. We'll pay you 100% of the Medicare rate. So sometimes pushing back and saying no has some dividends later on because it's a very clear line for the MCOs for what you expect, what you need for payment. And sometimes that's the only way to get them to pay you adequately. So knowing where your leverage points are, if you're the only game in town or not, is very important in the process. You should all be familiar with sort of doing a mini market analysis and know whether there are other agencies or organizations within your service area that furnish the same services as you or not, because that informs your leverage, and the MCO will never tell you whether you are the only game in town. So when they have to put together the provider network and show that they have adequate providers, they're not usually sharing that template with you. So you don't really know whether you are the one or two entities that are allowing them to meet their network adequacy requirements. Question?
Adam, I love this section. My question is, in a practical sense, how do you do this sort of analysis? Is there a systematic way of understanding who are behavioral health or primary care or other types of providers within a particular service area, and what types of services are they offering? Is there a site or a tool that's available to do this?
So one tool I would first look at is whether the state has made any of this data available. Like, for example, I was doing some work in Oregon, and Oregon actually put online all their, they call these readiness reports, when they went in to look at the MCOs to see if they had an adequate provider network. The reports actually indicated how many of each provider type that the MCOs had in their network. So any provider could go look at it and say, oh, is that me? Is that me? And am I the one that's providing, you know, ACT services or some other service? They would know immediately from that report. I don't know if Washington State has anything comparable where they have sort of released publicly the types of network in the MCOs. That's one. Other data, I mean, I would hope that you can find information out through working with the GCACH or the state associations that would give you some indication for the different spread of providers in different communities. I know that in the health center world, for example, the primary care associations always know where their sites, the FQHC sites are. When there's multiple sites in particular areas, they have that data available. I know you can go on HRSA's website and actually see where FQHCs are in different states. I don't know if there's anything comparable on the behavioral health side. I've heard historically that there's just not that kind of collection of information on behavioral health providers.
I think the Washington State Office of the Insurance Commissioner, which regulates the insurance companies in the state, does have some network adequacy requirements. I'm not quite sure if they post that information online, but I know that they do that analysis.
Now, the analogy I usually give is, you know, think about if you were, or think about these pharmacy chains. Can you imagine an MCO trying to put together a pharmacy network that didn't include some of these big chains like CVS or Walgreens or Rite Aid or whatnot? They couldn't. And they basically, those chains have driven community pharmacists out of business. And there are just basically 2-3 different large chain national drug trained pharmacies. They have enormous power. They basically have given themselves market power to be in managed care contracts and all of these managed care contracts, because a plan would not be able to offer pharmacy services without including them. When you are the only game in town, or one of 2 or 3, you have enormous market power. And if you combine that with the slide about the plans having an affirmative obligation to contract with you, to me that's very strong leverage. If there's 2 leverage points: the contractual obligation and the fact that you may be one of 2 or 3 providers rendering a service, you should have a lot of leverage over the content of your contract as well. What about timing? Timing can be an interesting source of leverage too for providers that sometimes is overlooked. The point in time where a provider has the absolute greatest leverage in negotiating contracts with MCOs is when they're establishing the network, the contract for the very first time, where the plan has to establish the network and meet the network adequacy requirements of the state. And the reason for that is because they basically have to show the state that they have it, and if they don't, they're viewed as not ready to accept any enrollment in line. Now, after that first year, that first check, states are not historically very good at monitoring plans networks after that point. They don't usually scrutinize them as much as they have the first time around. So I always tell providers, the time to negotiate for the best contract is when you're contracting for the very first time. You will not have the same leverage later on through amendments, unfortunately. It's just not the way it works. Because in the contracting stage, they are trying to include you. They need to get you to meet their network adequacy requirements. Think about it this way. When do you have the most leverage to negotiate salary with an employer? Is it when you're considering an employer's offer to join them, or is it year to year when you're going through your performance review? Most of us would say it's when we're initially taking the offer or not. The employer has to pay me enough to get me to say yes. To leave my current employment or maybe choose among multiple offers to get me to say yes. Year to year, am I likely to tell my employer, if you don't give me that 10% raise, I'm going to walk? Probably not. You're not usually going to just walk away from that offer if you don't get an adjustment on your salary. Most people don't do that. So the most important time is the initial contracting part, or when the state rebid. So if the HCA goes through a rebidding process when the term of their MCO contracts are up and they make everybody get a new contract, that's when you as a provider would again have the most leverage in the contracting process. Don't think that you should sign now and then deal with the details later. Because the most important thing is the initial contract. It's also why I frowned upon a lot of these, some of the MCOs in their bidding processes that will come to you and say, please sign this notice of intent, letter of intent, that you will join our network. Why do they want to do that? Because they get points for showing that they would have an adequate provider network. Do I like those letters from a provider perspective? No, because what are you getting in exchange? You're giving the MCOs a huge gift. You're basically saying you'll participate in their network. What are you getting back? Probably nothing. Usually, you're just agreeing to basically contract with them. So you get nothing for signing that letter unless it's part of your negotiation. So I'll sign this letter, but you have to guarantee that I get a VBP payment methodology, or I get paid under a capitated payment methodology. I don't want to just get stuck with fee for service. You can negotiate in advance what you expect in that contract later on, and that will be your price to sign that notice of intent or letter of intent to participate in the plan's network. You always kind of want to think about it from almost a transactional sense of, I'm signing this contract, what am I getting in return from the MCO? The time can be important. So it's important to stay abreast of these time frames. So if the MCO comes to you and says, we need to sign, you need to sign this contract in a week, understand, why are they giving you a week's time? Is that enough time for me actually to vet this contract and negotiate it? Is there anything behind that timeline that they're expressing? That's where it's helpful to get information from your state associations, your local groups, and your peers to figure out what's driving these deadlines that the plans are latching on. Or if you see all the plans amend their contracts at the same time and sending amendments to you, what's going on here? Is there a new contractual obligation that HCA has passed down to them that is motivating them? Do I have any negotiation leverage? And as I said, you have most leverage when you initially sign the contract, but contract amendments can actually give you leverage to negotiate things that you overlooked the first time around. I am not afraid of saying to an MCO, yes, we'll sign your contract amendment, but let's also amend the contract in this other area in order to do it, so that they get something from the contract amendment, but you do too, and you can make up for something that you overlooked or something that came to light after you signed the existing contract. Couple it with something else, because it's very hard, if you want to know, very hard as a provider starting an amendment process with a plan. Ever propose to a plan that they amend their contract? No, nobody does it. You may not even have the right to do it, as you'll see from the amendments clauses that I'll share, to do that at all. So leveraging on their amendment to fix something in your contract is a useful strategy as well. Next, competing on value. I already mentioned earlier that the state is pushing very hard towards value-based payment, moving providers away from volume. But it's helpful to think about and step back, how do I fit into this picture? What am I doing that is inherently more valuable than maybe another provider that I compete with? Why should the MCO want to contract with me? What's unique about my model of care? Am I in an integrated model of care where I combine physical and behavioral health services together, which is shown to result in lower costs overall for payers? Is that something unique that gives me my competitive advantage? So let's talk about that for a moment. The healthcare services market is a flawed market. As the slide shows, you have a big payer and then multiple providers typically contracting with that payer. It's a flawed market in part because the way the MCOs dictate to providers how much they get paid, and the methodology really favors the buyer, not the seller of those services. It's flawed because when you think about any other market you might participate in as a consumer, it doesn't work that way, right? If you go to your favorite restaurant and you see a menu, get the menu, and you look at the menu and you say, you know what, I don't want just one entree tonight. I'd like 3 entrees for $20. and you say that to the waiter or the waitress, what's the reaction going to be? What? There'll be confusion, right? Because the customer doesn't get to dictate the pricing methodology and price. The seller does. But in healthcare, it's exactly the reverse. The seller is basically just taking the pricing methodology of the buyer, which is the MCO. In this transaction, the buyer is the MCO who's buying these services. They dictate price and they dictate methodology to serve their own interests. But all health insurance is sort of premised on a business model that involves claims coming into them and them adjudicating them and paying some and denying others. That's their business model. And that business model works really well under a fee-for-service model, where there's an individual fee ascribed to each CPT code or whatnot for that particular discrete service. Does it serve the seller's interests? No. Does it serve patients or policy goals? Not really. It just promotes, basically isolation and fragmentation of services. There's no effort to coordinate services among providers. Providers are viewed the same by the MCO in the model. You may provide better value back to the MCO, but does the payer know that? Can the payer actually distinguish between the different outcomes that providers are receiving? Probably not. Most payers just see providers as sort of interchangeable commodities. They'll buy from this one, they'll buy from this one, and their goal is what? To pay the least amount possible to get that service. That's their financial motivation. And that's their business. It's really hard for states to push away and chip away at that business model, but Washington State is of course trying to do so. So what can you do to try to chip away at the business model to encourage, like we've already heard, MCOs to maybe move out of their comfort zone to do something different? So what I hear all the time from MCOs, from Medicaid managed care payers as well, is you have to explain back to them what their cost is. Because remember, the MCOs don't really care what they pay an individual provider for services. They have responsibility to pay for all the services that the member is entitled to under the contract. So they are under a population-based methodology. HCA pays a premium to them per member per month for all the services they are contractually, legally obligated to render. So they care about the total cost of care. So from their perspective, the arguments that go over best are not, from an individual provider, are not, my costs are going up. That's not going to do much for an MCO. Arguments that make more sense to them is, can you save me money? Can you do something different that will actually help me manage my total cost of care? If a patient is adhering to their drug treatment and not utilizing services or hospital services for chronic care, physical health conditions, that can be better for the MCO. If you can reduce ER visits and other preventable hospitalizations, that's great for an MCO because that's where a lot of their costs are. Sometimes a third of their costs are in hospitalizations. Can you reduce total cost of care through some payment methodology? Usually that's where MCOs are willing to have a discussion. Will all be willing to have? Will all of them be? No, probably not. You probably know from your own experience in contracting with managed care companies that some are more friendly to providers than others. So you might start with those friendly MCOs and try to work out a pilot or a payment methodology. And you'll have to explain to them, if you pay me by this methodology, I can likely help you reduce your total cost of care because this is how that works. That's the start. That should be the starting point for any discussion. You have to frame your argument in a way that advances the MCO's interests. When I was a lobbyist for a couple of years at the trade association, my mentor, who had been the chief health lobbyist for ARP, explained to me that to be a good lobbyist, you have to solve the member's problem, member being the congressperson or the senator. And the reason is because you have to advance your own interests in a way that solves the member's issues. So the member might have, constituents complaining to them about the lack of access to health care or whatnot. And you have to frame your solution in a way that helps them solve their problem. Same is true in any negotiation, even with an MCO. How is the payment methodology that you're proposing going to help the MCO manage the total cost of care? If you come up with a strong reason there, a rationale there, that is the framework for an argument to them for why you should be paid a certain way. And typically it takes data usually to show that. Some of you might be thinking to yourself, that's a nice idea, but we don't have the data to show how we impact total cost of care. Well then, you know what you need. You know you need to find a mechanism that will give you information on the MCO's total cost of care for the patients you see. Put that sort of in the back burner for now, because we'll come back to that issue. Accessing data that you need to demonstrate your value in the system, because there are some ways that you might want to be setting yourselves up to access that data. Yeah.
So Adam, I might be jumping ahead here, but can you ask them for that information, for example, to compare your performance against a peer group in your community or vicinity?
You can, but many of them will say no and refuse to give you that information. They'll claim maybe HIPAA confidentiality rules or ridiculous Part 2 rules that they think they can't release some of that information to a provider. But really, it's not true. Those are just arguments they're putting up for you. So I'll talk about in a couple of slides. I think I have some slides about how you can counteract some of those arguments to argue for that data. What about downside risk? Are you willing to incur any downside risk in your contracting model with the MCO? Downside risk means that if you misestimate, you're taking a loss, not the MCO. Why would an MCO even be attracted to a downside risk arrangement? Because it's a way for them to minimize their own financial risk. Health insurance companies are in the business of managing risk. Of course, they get their own secondary insurance to cover big loss, big claims, and losses like that. But whenever they contract with a provider on a capitated basis, for example, or even shared savings or shared risk to align, and what they're basically doing is trying to downstream some of their financial risk, right? Because if I'm a behavioral health provider and I get paid a PMPM, a fixed amount for behavioral health, it means I get one fixed amount regardless of how much service the patient is that I'm providing to their enrollment. They're not paying anything more, even if I have patients that continue to come in for more services than I estimated initially. They get to pay you a fixed amount. So that's desirable from an MCO because they've capped basically their outlay for that particular service. So many MCOs do like capitated models from that financial reason because it limits their financial exposure. Do they like it for all services? Not usually. I've had many MCOs come to me and say, we don't want to pay a capitated rate for primary care because we don't want to create a disincentive for that provider on stinting unnecessary primary care. In fact, we want to incentivize primary care. So we want there to be a volume-based incentive for them to furnish more preventative services and primary services because we know each time preventative primary care services is furnished, it's less likely an individual will show up in the emergency room or in a hospital because they'll be more likely to have care done. So some payers are resistant to capitation for certain types of services. I haven't heard it for behavioral health, but there are reasons and ways that you can counteract some of those concerns as well. Bundled rate payments, case rates, they do the same thing. So we get a fixed amount for a service, a condition, or type of treatment that fixes the MCO financial exposure. Some of them look like that. And shared savings and losses that we'll talk about in more detail, those types of arrangements help align incentives between the MCO and the provider so that everybody is aware of the total cost of care. Communicating your value. You may not think about actually what your pitch is to an MCO, but I would encourage you to do so. Just like you have probably a reputation in your community at the patient level, where people know about you, what your services are, who you are, what you do, why you do what you do. It's also important for the MCOs to hear that pitch too. Because if you want to set yourself up to do well, you want the MCOs to know who you are. If they are rolling out a new pilot payment model or methodology, a new capitated approach, or something different, or value-based payment contract, who do you want them to call? Probably you. So you have to get your name out. I had a behavioral health provider who attended one of my trainings. They came up with a one-page, this is who we are, that they would use whenever they sat down with an MCO provider rep to introduce them. They would say, this is the scope of services. We've been around in the community for 30 years. This is our model of care. These are some of the innovative things that we're doing. Because they wanted to look like a very attractive partner to that MCO. Because they wanted favorable treatment, not just in the existing contract, but in future pilots and other programs that MCO might offer. Because many MCOs, they don't offer identical contracts to all the providers. They all pick and choose which providers that they think have the capacity to take certain types of arrangements.
So Adam, is there any evidence or any studies to show that those providers that are using medical technologies provide greater value for that patient care? And where would that
yeah, I'm a total policy wonk when it comes to many of these issues. So there is a vast literature showing the value, the total savings from patient-centered medical home models. I think there's also some studies that show that they didn't save money, but there's certainly evidence and studies that you can marshal on your behalf to show the value of a patient-centered medical home model. And the policy literature, Google that information and you'll find studies. There's also a lot of entities that do reports based on those studies. So the National Association for State Healthcare Policies, I got one of the, I think I'm getting the acronym wrong, but some of these other associations will actually do the research for you, and then they come up with these reports to demonstrate the value from some of these payment models, like patient-centered medical home models. For FQHCs, there's studies out there that show the cost, they compare the cost between FQHCs and other non-FQHC providers for Medicaid patients and for Medicare patients, and it's usually lower total cost of care. If you don't have the actual claims data, I know somebody asked, where can I get this data? If you don't have the actual data that you can marshal against an MCO, you can certainly start with the academic studies to show that the model of care has value. And hopefully it's not the first time the MCO is doing this data, but there's data that you can latch onto to show it. I've also had providers who basically got data from an individual MCO and then used that in their negotiations with others. They went to they went to one MCO that they had a good relationship with, and they said, share us some of the cost data that you have for our patient population. And they realized that they were basically saving that MCO about $60,000 each time they avoided a rehospitalization of a behavioral health patient. And they went to the MCO and they said, look how much money we're saving you through our transition care process that we developed. This is something that we came up with that's not covered under fee-for-service, but we basically manage the transitions from inpatient facilities to outpatient behavioral health, and we're saving you tons of money. Think about how much more money we could save you if you actually contributed something, consistent with the value that we're returning to you, and get more money for doing that work. And the MCO said, that is kind of interesting. You are saying that. The provider said, we could grow this program and have more capacity if you funded it through some funding mechanism. And they took that data to other MCOs, and they said, this is what we're doing. We can show you a return on the investment. And it was a starting point for a discussion. Is it going to win every time? No, there's nothing Surefoot about it. It's a negotiation. But at least they were positioning themselves to have the value-based conversation with the payer, showing this is what we can do, this is what we need to support the staff for this program, and this is the return on that investment to the payer, to the MCO. So how do you meet MCOs at the right level? Because many of you may have had conversations with provider reps, and they are not very fruitful efforts. I can completely understand they're kind of low on the totem pole at the MCO. If you're proposing anything innovative or out of the box, you may have to go up a little bit higher on the food chain at the MCO. So all the MCOs, from what I understand, have, for example, directors of behavioral health services. That might be the appropriate person to start with if you're a behavioral health provider. Don't hesitate about reaching out to the MCO medical director. Have your medical director reach out to their medical director and set up an opportunity to meet coffee at one of the conferences that you know that they're going to be at, so that you can develop these relationships. They're organic. When people come to me and say, how did that provider get that relationship? Sometimes it's just because they struck up a conversation at a conference and they became sort of known to that MCO, and that started the relationship. And that's fine, but you usually have to knock on the door first. Don't expect the MCO to knock on your door. You're going to have to knock on some of the MCO's doors that you think is going to be, open, but you have to knock on their door and set up the conversation to explain who you are, why it's in their interest to contract with you, what you need different, and what could be a win-win for both parties. Are these easy collaborations to get? Not if they're out of the box, not if the MCO doesn't have them before. They can take 9 to 12 months to get some of these pilots up and running, which is why I encourage you to do that sooner than later, because of the huge time frame and investment of resources to get any of these innovative models off. I think if you just want a capitated arrangement, that should not be one of those that take a lot of time, because as I mentioned, most of the MCOs offer capitation even to behavioral health providers in Washington State. They've been told they have to basically model the BHO financing mechanism, and so many of them have done so. Collaborations are often key to open up the door to value-based payment arrangements And many of you probably have different types of collaborations already going on. And some of the collaborations are usually just by contract. So let's say I'm a behavioral health provider, I contract with a physical health provider or primary care provider, some kind of joint venture, where now you are jointly doing activities together to make sure that patients are served by both entities in a way that's more coordinated. Many of you would just have, a little mini governance committee. Maybe the two CEOs meet from time to time, and then they bring in other staff as needed. That's one model for integrated care that's very, very common. Another model is partial integration, where you actually form a new type of entity, legal entity, to merge not just the delivery system level collaborations activities, but because you want to merge some of the financing too. You want more money to come into the jointly controlled entity, and then that will sprinkle down. The third model that I see are mergers and acquisitions, where providers say, you know what, we want to merge and be part of a larger organization to deliver services. We think we can have cost savings, economies of scale, and additional leverage in discussions with MCOs because now we're larger. It's like some of the MCOs in many cases are merging with each other. Why are managed care companies, why is CVS Health, merging with, buying Aetna? Why are some of the big companies like WellCare and stuff in merger discussions? Because they're feeling threatened. They think in some communities, providers have too much power, negotiating power, market power, so they are trying to consolidate on their end in order to increase their leverage. And interestingly, there's even some systems that look like they're fully integrated, but are really more like joint ventures. When you look at the Kaiser Permanente health plan, Kaiser Permanente is a brand name. There's no legal entity called Kaiser Permanente. It's actually a contractual relationship between Kaiser Foundation Health Plan, that nonprofit HMO, and a Permanente medical group in each of the communities. They have a contractual relationship. It's exclusive. So, of course, the Permanente medical group is only working for Kaiser, but it's a contractual relationship. The health plan does not employ all their practitioners directly. They contract exclusively with their Permanente medical group. And then sometimes they contract and own hospitals as well, and the health plan typically owns those hospitals. But it's a contractual relationship. But from a branding perspective, people in the market, they don't know that. They just see it as Kaiser Permanente. They see it as a fully integrated model. So I point that out because you may be part of a system or a network and have contractual relationships where you're branded all together. Maybe the patient doesn't see the differences, that you're still maintaining your own autonomy yourself. They just see the branded end, and that's possible too for many types of integrated care model arrangements. So the integrated care models at the delivery system level often have providers that provide primary care and behavioral health working together. Some are shared referral arrangements where you are agreeing to refer patients back and forth and usually transfer medical records and data to help each provider coordinate care. Sometimes you have co-location agreements where you basically open the doors and say, why don't you come here into our business, our physical space, and render services that is co-located so that patients don't have to travel to other places. Every time I go to my doctor, and I have to go down to that phlebotomy lab. I know that phlebotomy lab, even though it's branded as my doctor's office, is really not. It's a private contractor that runs that phlebotomy lab. Same thing can be done with primary care and behavioral health. Sometimes you do purchase of services. So I'm a behavioral health provider. I want to integrate care. I don't want to employ the practitioners directly. I'll contract with the primary care provider. Their employees will come over to my site. I will render services. I will bill for those services as if they're my own providers. That's a purchase of service. Works the other direction too. Primary care provider saying, I need behavioral health staff. I'll contract with a known behavioral health provider. They will bring their staff over, and I will bill for their services as if it's my own. But I purchased and leased that employee's time. And then merger, the ultimate joint venture. You usually contract first, see what it's like, kind of date. If it works out okay, and then you merge together if it's all going to work out. Many mergers actually don't get consummated. They don't actually go all the way through because providers realize that they're not compatible as entities. They can't bring the two organizations together fully. And that's on the delivery system level. Where Washington State really is pushing, where New York State is pushing, where nationally many policymakers are pushing, are providers not to stay just independent, but to be part of provider networks and collaboratives that merge financing systems among them. Because many policymakers just basically say, and I think they're right, you can't have delivery system reform and changes in the absence of financing. You have to change how payment is being made to providers to support the care that you want them to do in a way that works for them in order to get big shifts in care that are sustainable. For many networks, this work where providers have said, we want to create a new legal entity. Some of them are called independent practice associations or IPAs. Others are called accountable care organizations or ACOs. Sometimes you throw in the archaic term of management service organizations or MSOs. These are provider-owned legal entities, and they allow the financing to be integrated. So not just the care, but the financing. What do I mean by that? That could mean that the IPA contracts with an MCO under a value-based payment arrangement, where now that IPA is under, let's say, a shared savings or a shared risk arrangement with an MCO and has to manage the total cost of care. And it works with the providers in that network to help achieve that outcome, to help manage the total cost of care. But now that legal entity is the contracting entity with the MCO. Why is that good? From the perspective of the providers, they may not have enough lives individually, but when they come together and form an IPA, now there's enough lives to make it worthwhile for them to spread that risk over a number of lives. The IPA can invest in buying EHRs or care management platforms to allow them to manage the total cost of care. Now they can go to the MCO and say, we need a claims stream. We need to have access to your claims data so we can identify those highest risk, high cost patients to engage in interventions early on. Now you have a business platform to do that work, and now we'll integrate the finance. It also leads it to the IPA to decide how to distribute the proceeds from an effective collaboration, right? So if there's shared savings at the end of the year and the IPA's earned it, the IPA can meet with the providers and say, okay, how do you want to split the pie? We succeeded. Now we have to distribute this in a way that makes sense. But don't let me do that.
No, it's frozen. I'm sorry.